Welcome to the third part of our lecture series on viral hepatitis. And during this presentation, we are going to discuss hepatitis B viral infections. I am Dr. Teke Apalata, a specialist in clinical microbiology. So let's look at hepatitis B infection. Now, how big is the iceberg? You know, hepatitis B has been a major problem for a very long period of time. And let's see how big is still this problem, you know. So in 2015, the World Health Organization estimated that about 257 million people were actually living with chronic hepatitis B infection. 257 million of people in the world in 2015, they were living with chronic hepatitis B infection. This just tells you how big is this problem. And almost 887,000 people died, you know, from this condition because they developed cirrhosis, they developed cancer of the liver, and they died. They succumbed from hepatitis B chronic infection. So this is really a very, very big problem. And as of 2016, about 27 million people, that is almost 10.5% of all people estimated to be living with hepatitis B, were aware of the infection. Only 10.5%, you know. So 257 million are living with the condition. Only 10.5% of these people are aware, you know, of their status. And only about 4.5 million out of those who are aware are actually diagnosed and receiving treatment. They are receiving treatment. So this tells you that many people are sitting with this problem without knowing that they are infected, that they are progressing toward the development of chronic infection, and they are going to develop cirrhosis, they are going to develop liver cancer. So many people don't know about this. But the only good news is that according to the latest World Health Organization estimate, the proportion of children who are aged below 5 years, you know, who have been living with a chronic hepatitis B infection, actually the proportion of those children dropped. You know, it used to be around 5%, you know, in the pre-vaccine area, you know. But now, in 2019, the prevalence is below 1%. So we move from 5% to 1% for children below 5 years. And this is because of the vaccine, the successful vaccine that we have that can be given, you know, to women to prevent, you know, vertical transmission of hepatitis B infection to their unborn children. So this is a very big problem. Now, let's look at the geographical distribution of this problem, you know. What are the regions that are heavily affected? You know, we have the WHO Western Pacific region and the WHO African region are heavily, you know, affected. You know, we have around 6.2% for the Western Pacific and 6.1% of adults in the African region have hepatitis B infection. So this is a big number of people who are infected. Then those two regions are in the top. Then you will find the Eastern Mediterranean region, you found the Southeast region. So the Eastern Mediterranean, you have 3.3% of all adults are infected. The European region is 2% are infected, and 2% is the Southeast Asia, and the European region is 1.6%. Then the least to be affected are the Americas, that is less than 1%, of global distribution of hepatitis B infection. So this is really a big problem worldwide. It's, affecting all different regions of the world. This is the structure of the hepatitis B virus. This is how it looks like. It is a genomic DNA. This is a genomic DNA. It is a double-stranded. You can see 2 strands of the DNA. That's what we call double-stranded. But it's called partial. It's a partial double-stranded DNA because here you can see this second strand is not complete. It's not complete, And it has 3 main antigens. We have here, we have what we call the surface antigen. This is what we call in red, that's what we call hepatitis B surface antigen, When we test for this, you must know that this is what we call hepatitis B surface antigen. And we have here in blue, we have what we call the co-antigen. The co-antigen. So hepatitis B C antigen or co-antigen. This is the S antigen or surface antigen. And inside we have the hepatitis B E antigen or envelope antigen. Envelope antigen. And the E antigen is really a marker of infectiousness. So if the E antigen is positive, it means that this patient is highly infectious, or there is an active replication of the virus. So the surface antigen is what we do as the initial test to try to see whether our patient has an infection or not. And this is also the antigen, that's the surface antigen that you see here that has been purified to make a vaccine, the vaccine that we have against hepatitis B. It's actually, because of the surface, it's made from the surface antigen. Now, let's look at the life cycle of this virus. We say that this is the virus. It will then infect, so it will attach, fuse, and penetrate the liver cells that we call hepatocytes. So the virus will attach to an hepatocyte, and after attachment and fusion, it will then go into the cells, the hepatocytes. So then subsequently, it will be taken, moved from the cytoplasm to the, it will be transported to the cell nucleus. So here in the cell nucleus, this, DNA of the virus that converts to what we call covalently closed circular DNA, that we call cccDNA, the cccDNA. So the original DNA becomes a cccDNA that we call covalently closed circular DNA. And this cccDNA will then convert into what we call a pre-genomic RNA, template that will allow viral replications, it will allow the replication to take place, in the cytoplasm after encapsulation and the reverse transcription of the virus. So then you will have new variants that are developed, and some of those variants will then re-enter the cell nucleus, and the others will acquire new enveloped proteins, to exit the cells so that they can infect new cells. And during that process of active replication, there is a lot of E antigen that are released. So that's why if you are exposed with the blood of a patient who has surface antigen positive and E antigen positive, it means that this patient has an acute infection and it's actively replicating. So the probability of you contracting hepatitis B from that person is extremely high. It is extremely high. So what I'm saying is that hepatitis B virus is a partially double-stranded DNA. It has a partially double-stranded DNA genome, and it has 3 important antigens, one inner core protein that we call hepatitis B co-antigen. We have an outer surface coat that we call hepatitis B surface antigen, and we have a non-structural nucleoproteins that is a secretory form of co-antigen that we call hepatitis B E antigen or envelope antigen. Okay. Now, in addition to those 3 important antigens that we have to remember, we also have 8 different genotypes that are named from A to H. So those 8 different genotypes are very important because first, they influence differently the cause of infection. So if you are infected by specific genotype, there are some genotype that if you are infected with, you might develop a much more severe infection, or you might rapidly progress toward the chronic infection. And it does not only affect the cause of infection, but there are genotypes that also affect the responsiveness to antiviral treatment. So some genotype, you might recover much more faster than if you are infected with a different genotype. So we will see that when we discuss the management of this patient. So the concentration of the virus is different when you find them in a different body fluid. The concentration of the virus is extremely high in the blood, in the serum, and wound exudate. So we need to be very careful being in contact with people's blood, serum, or wound secretions. And it is moderate in the semen, in vaginal fluid, and the saliva. So this is what makes hepatitis B to be a sexually transmitted disease, a sexually transmitted disease, because the concentration of the virus is there in the semen, in the vaginal fluid, in the saliva. It is there. But the concentration of the virus is low or sometimes not detectable in the urine, in the feces, in the sweat, in the tears, and the breast milk. It might be there at a very low concentration, or sometimes it's not at a detectable level. So, what are the different modes of transmission of hepatitis B infection? It can be transmitted via parenteral route, especially with people who are using IV drugs, or healthcare workers who can sustain needle stick injuries, and so on. So through the use of needles, or any sharp objects, so they can, contribute to the transmission of this infection. Secondly, we say that it's through sexual intercourse. You can contract hepatitis B infection if you do unprotected sex. And what we call vertical transmission or perinatal transmission. Perinatal transmission involves vertical transmission. It means that mothers who are infected, they can then transmit infections to their children. So perinatal transmission is the main means of transmission, especially in high prevalence population where the rate of hepatitis B is extremely high. So those are the major routes of transmission. But what are the risks, especially to the healthcare workers? The risk of hepatitis B transmission to healthcare workers is reduced, can be reduced because of the vaccine, because healthcare workers are among the subpopulation that they must receive a vaccine. Before that, you start practicing as a clinician, as a nurse, or whoever in the hospital setting, you need to ensure that you are vaccinated. And when you are vaccinated, the risk of you being exposed to the blood or body fluid of other patient for you to contract an infection is extremely very low. Okay. And the other thing is that in the past, we used to have what we call routine booster doses of hepatitis B vaccine for healthcare workers who are known to have responded adequately to primary vaccination. But now we know that this is no more necessary. And it is not necessary. Why? Because the protection persists even in people whose antibody titers have declined significantly. What am I saying? I'm saying that if you receive the 3 doses of vaccine and you develop antibodies, you are protected. Even after several years, when the antibody titers becomes very low or decline significantly, and you come across the virus, you become exposed to the blood or body fluid of an infected patient. Since the incubation period of the hepatitis B infection is very high, in between, you have T cells that have what we call anamnestic memories or anamnestic response. It means that you have T cells that have a very long immunological memories. They will be able to remember the virus and have your antibody levels build up before that the incubation period of the virus is reached. So because of that, there is no need for a booster vaccine. There is no need for a booster vaccine because this anamnestic response occurs within 2 weeks of exposure to hepatitis B, for people who have been exposed already. So you can be able to have your antibodies back, while the incubation period for the infection is still very long. Now, a healthcare workers may be considered to be immune to hepatitis B when there is evidence of 3 doses of hepatitis B vaccine given at 0, 1, and 6 months. So this is, we give 1 month later the 2nd dose, and after 6 months, we give the 3rd dose. Then we can consider that you are immune. And also after documenting the presence of antibody, anti-hepatitis B surface antigen, surface antibody titer, after doing the test at least 4 to 8 weeks following the last dose, 4 to 8 weeks following the last dose, we can take blood and test for the presence of antibodies, anti-hepatitis B surface antigen. So we can be able to see that. Now, or if the healthcare workers is anti-hepatitis B surface antibody positive and anti-hepatitis B co-antibody positive, it's also an indication for protection. But about 5 to 10% of healthcare workers may fail to respond to the vaccine. We must remember that That's why it is important that after you complete the 3 doses, you should test, because 5 to 10% of healthcare workers can fail to respond. And this could be because maybe they are already infected, with the virus, or it's just they have problems with their immune system and they are not able to respond to this antigen. So healthcare workers who then fail to make detectable antibodies after 2 courses of vaccine should be checked to see if they are not already infected. So those cases of vaccine failures who are not hepatitis B infected should then receive the immunoglobulin as a post-exposure prophylaxis in a case that they are exposed. So you can then give them a post-exposure prophylaxis. So every time they come into contact with an infected patient, you can give them a immunoglobulin that is made of antibodies, because themselves they are unable to produce the antibodies. So when you give them immunoglobulin, it means that you provide them with antibodies that are able to protect them at that particular time. So the incubation period, I said, it's very long. It's 2 to 3 months, but sometimes it can go up to 6 months, So from 45 days to 108 days, up to 6 months, the incubation period. So it's extremely long. And patients who are below 5 years, only less than 10% of them might develop jaundice. But from 5 years and above, almost half of patients can develop jaundice. Then other signs might include low-grade fever and so on. And acute case fatality rate ranges from 0.5 to 1%. And chronic infection development toward chronic infection depends also on the age group, because children below 5 years, about 30 to 90%. So if you are infected when you are a child, especially below 5 years, you have 30 to 90% chances of developing chronic infection. But from 5 years of age, if you are infected at that time, you have only 2 to 10% chances of developing chronic infections. And premature mortality rate from chronic liver disease is between 15 to 25% of cases. So this is how we make the diagnosis of acute hepatitis B infection, doing serology tests. So the first antigen that we look for is what we call surface antigen. We test for the presence of surface antigen. Surface antigen, the titer starts increasing 4 weeks after exposure. 4 weeks after exposure, it starts increasing. Then it reaches its peak around 12 weeks following exposure. Then it starts decreasing. At 24 weeks, it means that 6 months after exposure, you don't normally need to see hepatitis B surface antigen. So if hepatitis B surface antigen persists beyond 24 weeks, it means that beyond 6 months, this is what we call chronic hepatitis B infection. This is chronic hepatitis. So during acute, you have surface antigen that is positive, but you also look for IgM, anti-co-antigen. So the IgM anti-co-antigen in yellow, the IgM, you will see that this starts increasing after 4 weeks, and then 6 weeks later, you see the antibodies that start also rising. The IgM anti-co-antigen starts increasing, So if you see surface antigen positive, IgM anti-co-antigen positive, with or without hepatitis B E antigen, this is what we call acute hepatitis B infection. Acute hepatitis B infection. Now, if S antigen is persistent, normally S antigen must go down after 6 weeks. IgM will go down, then the IgM will be then replaced by IgG, and the anti-surface antigen, antibody anti-surface antigen will be present. So this is an indication of recovery, following an infection. So when the IgM goes down, you have the total antigen that is high, the anti-S that is present, the anti-S is present, then S antigen negative, IgM antico negative. So it means that your patient recovered from the acute infection. So how do we prevent acute hepatitis B infection? Especially in the healthcare setting, we need appropriate waste management, especially handling of disposable needles by healthcare workers to avoid needle sticker injuries. Screening of donated blood, to ensure that the blood does not contain hepatitis B virus. Screening of the pregnant woman. All pregnant women need to be screened if they don't have hepatitis B infection, so that we can prevent perinatal transmission. Vaccination of healthcare workers, it's recommended. Vaccination of children, it's recommended. Safe sex with hepatitis B infected individuals. Post-exposure prophylaxis, and post-exposure prophylaxis should be done within 7 days following exposure by first getting the hepatitis B immunoglobulin. They will give you immunoglobulin that have antibodies. Then after that, you will then receive your 3 doses of vaccines. So those are different ways, strategies on how we can prevent acute hepatitis B infection from taking place. Now, when we speak about vaccines, we must know that this is a highly effective recombinant vaccine that is available. And this vaccine can then be given to those who are at increased risk of hepatitis B infection. That's why we give healthcare workers. Now we are also giving children, or maybe if someone is raped, you can also be able to give the vaccine. So we give to neonates as part of universal vaccinations in many countries. We also say that we have hepatitis B immunoglobulin. This immunoglobulin may be used to protect persons who are already exposed and they were not vaccinated. So it happens that they are exposed. So it is efficacious within 48 hours of the incident, but it can be given up to 7 days post-exposure, but it's highly, highly efficacious if you give it 48 hours following exposure. It may also be given to neonates who are at increased risk of contracting hepatitis. So it means that especially if the mother was not screened during pregnancy, and now during birth we found out that the surface antigen is positive, the E antigen is positive, it means that she is highly infectious and the child might have a high risk of high probability of developing hepatitis B infection. So immunoglobulin can be given to those children. And the other measures we say we have to pay attention to transfusion. So blood we need to screen the blood donors. We need to take a lot of precautions about other body fluid. So in general, as I say, the clinical recovery can be expected, following 3 to 6 months post-exposure, where the surface antigen, will disappear. But you might see some lab evidence of liver dysfunction, some liver enzymes might still The titers must still be high. They might persist for a while. The mortality is high with a superimposed hepatitis D. I say that hepatitis D, during the overview of viral hepatitis, I say that hepatitis D does not occur if there is no hepatitis B. Now, people who are infected with hepatitis B must avoid to be superimposed, to acquire superimposed hepatitis D infection, because that will precipitate their complications, and it will lead to mortality, to high mortality rate. So 3 to 5% of people with acute hepatitis B will develop chronic hepatitis B infection, but 95%, of neonates and infants. So if you develop acute hepatitis B as a neonate or infant, 95% of them will develop chronic hepatitis B infection. The treatment of acute hepatitis B usually is the same for acute hepatitis A. If you you missed our lecture on hepatitis B, go and check our part 2 of this lecture where we discuss hepatitis A infection. So antiviral therapy is usually prescribed only in the cases of very severe fulminant hepatitis B infection. But otherwise, if it's not a very severe condition, it's bed rest, good diet, good hydration, so that you can recover. Encephalopathy or severe coagulopathy indicate acute liver failure, and these will then lead to hospitalization. So hospitalization here is mandatory for patients who will have complications like encephalopathy or severe coagulopathy. Now, what are the possible outcomes following an acute infection? So we say that following an acute infection, 3 to 5% of immunocompetent adult patients will develop chronic infection, or 95% of neonate and infant acquired infection will develop chronic infection. So those will then develop chronic hepatitis. Then 12 to 25%, almost a quarter of those patients with chronic infection in the next 5 years will develop cirrhosis. And the cirrhosis in the following 5 years, those patients will develop in a hepatocellular carcinoma. That's what we call a cancer of the liver. They will develop a cancer of the liver, then they will require liver transplant, and many of them will succumb from the disease, so they will die. So those are the possible outcomes following hepatitis B acute infection. And how do we make the diagnosis of chronic hepatitis B? We say that the surface antigen in red, the surface antigen persists beyond 6 months. This is the first thing you look, surface antigen that persists beyond 6 months. The IgM is now negative, it's replaced by IgG, and the total anticore antigen is still there, so it's positive, total anticore, surface antigen positive, IgM replaced by IgG, and hepatitis B E antigen can be there or not. It's not a problem, but you make the diagnosis of chronic hepatitis B infection. And this is a different outcome, regarding hepatitis B infection when it comes to age. Remember that, many children will develop, if you are infected, early, so chances are that you are going to develop chronic infection. So those who develop early, or those who develop infection early, they progress toward chronicity. This is the natural history of chronic hepatitis B infection. It happens in 4 phases. The natural history of infection happens in 4 phases. The first phase is what we call immunotolerance. Immunotolerance you see that if you do PCR, the hepatitis B virus DNA is present with so high viral load. You will see here it's very high. The E antigen is usually present, the S antigen is present, and the ALT, the liver enzymes are still very low, but they start picking up, they start increasing, but they are still low. The level is still low. The titer level is still low. So this is what we call immune tolerance phase. Then you reach a level that's what's called immune clearance. During immune clearance, the level of hepatitis B virus DNA, it becomes variables. You see up and down, up and down. And also the E antigen is still there, the S antigen is there, and the ALT level is also, increasing. It's also variable during immune clearance phase. Then you reach the third phase that we call immune control. So where your antibodies are now trying to control the disease. This immune control, it's a non-replicative phase. So the virus is controlled, it's not be able to replicate. So you will see that the E antigen becomes negative because there is no active replication. And the antibody anti-E antigen is positive. Surface antigen is also negative because your body managed to control the infection, and the surface antibody becomes positive. So even if you do PCR, you will see that the viral load is extremely low. It's less than 10 to the power 5 copies per ml of a specimen. So you will see that the viral load is very low. The infection is controlled. That's what we call immune control phase. So during this phase of immune control phase, most patients will have normal ALT. The liver enzymes are normal. You see low or undetectable hepatitis B virus DNA. You will see that the S antigen, if it's positive, but the E antigen must be negative. But in many cases, the S antigen will also be negative, and the anti-co antigen and the anti-S antigen will be positive. Then the fourth phase is what we call the reactivation phase that leads to chronic hepatitis B infection. So some of the patients might control the infection initially. Some patients might initially control the infection. Then later on, they might reactivate depending on a number of reasons, And some of the reactivation happens usually as a result of a precom mutant. There is a mutation in one of the virus will mutate. It can be a precom mutation, or it can be a spontaneous mutation, of the preco or co-promoter region of the virus. Then the new mutant will then replicate because your body, the antibodies that are there are not able to control those mutants. So you reactivate. Then you will see the viral load start increasing, and the patient might then develop cirrhosis, over the years. So the risk factors for reactivation, it's mainly the male gender. So male patients are able to reactivate more than females. If you are infected with genotype C, hepatitis B virus genotype C, remember I said there are 8 genotypes from A to H, but if you are infected with genotype C, chances that you will reactivate is very high. So if you are a male patient infected with genotype C, advanced age, and you are a smoker, you drink alcohol, chances are extremely high that you are going to reactivate. Co-infection with hepatitis C, co-infection with hepatitis D, co-infection with HIV with a very low CD4 count, those are also serious conditions that will make many patients to reactivate. So that's why when you manage patients with hepatitis B, you have to screen them to exclude the possibility of co-infection with hepatitis C, D, and HIV. You know, so, and you also need to do genotyping to assure that the patient does not have, you know, to know what type of genotype you are dealing with, because it will influence the treatment. So now the question is, do you ever really get rid of hepatitis B infection because of that possibility of reactivating and progressing toward serious infection? You see, so this is the cccDNA that is there in a latent stage in hepatocyte. It's living there in your liver cells, you know, the cccDNA of the virus. So when there are any factors during acute infection, you have replication, you have production of new virions, then your T cells will then be able to control the infections. Remember, during different phases, during immune control, they are able to control, to destroy all those virions. But for any reason, anything that affects your T cells, like HIV infection, use of steroids, or chemotherapy for people who have cancers, or people who use steroids, or people whose immune system is affected for any reason, so their T cells are affected, then those people will reactivate. They will then become, you know, they will then develop an infection, because the replications of the virus will become more active, and those patients will then progress toward reactivations. So you will see that the E antigen becomes positive again. During this reactivation, the ALT level will increase, the viral load will increase. So those are what we found during hepatitis B reactivation. Reactivation moves also in different phases. After immune tolerance, immune clearance, you have immune suppression and immune reconstitution. So those patients develop what we call immune reconstitution syndrome. So this is a summary of serologic patterns in hepatitis B infection. So to make the diagnosis of acute hepatitis B, first the surface antigen should be positive. You have a negative anti-surface antigen, it's not there. You have IgM anti-co antigen is positive, it's a IgM. The E antigen can be positive, or it might not be positive, but this is an acute hepatitis B infection. And this is a chronic, during a chronic hepatitis B with active replication, the surface antigen will persist above 6 months. The anti-surface antigen is still negative. The anti-co IgM is now replaced by IgG. That's what makes you think that this surface antigen has been there for more than 6 months, because you don't have IgM anymore, you have now IgG, and your E antigen is positive. You make the diagnosis of chronic hepatitis B with active viral replication. Now, chronic hepatitis B with low viral replication, its S antigen is there, anti-S negative, IgG anti-co is there, but the E antigen is negative. But now we have anti-E positive. This is chronic with low viral replication. This is chronic with low viral replication. Now, recovery from hepatitis B following immunity is that S antigen will become negative, anti-S positive, IgG is there, there is no hepatitis B E antigen. Here you know that this patient recovered because of his own or her own immunity. Now, to make sure that this is just someone who is just vaccinated and never been exposed, everything will be negative except for antibody, anti-surface antigen. That will be positive, but everything else is negative. You know that this is a person who has just been vaccinated. Chronic hepatitis B, we say that persistence for more than 6 months, then you need to look if there is an indication for active replication, you test for E antigen. And in adults, if E antigen is negative, and ALT, the liver enzymes are normal, this is what we call healthy carrier. So this patient can then infect other people, but himself is clinically stable. Those are what we call healthy carrier. Okay, so the surface antigen persists for more than 6 months. The E antigen is negative, the ALT is normal. So this guy is a healthy carrier. Now, however, you need to do a periodic evaluation to try to see if the ALT, the enzyme, liver enzymes are not increasing, you know. And the other thing you can do to try to see, check if the patient is not co-infected either with hepatitis D or hepatitis C. So you need to double check that. So what is the treatment for chronic hepatitis B? The objective is that the treatment is aimed at reducing and maintaining the viral load to the lowest possible levels. This is the aim of the treatment, you know, how we can decrease the viral load. And it will then normalize the liver enzymes levels, you know, to allow histologic improvement of the liver cells so that they can recover. We also aim to obtain seroconversion, especially to have anti-hepatitis B E antigen present so that we don't have active replication of the virus. So those are the objectives of the treatment. It's not like we are trying to get rid of the virus, but those are the things we are trying to achieve. Now, what are the indications? If you have a patient with active viral replication, it means that the E antigen is positive. The viral load is above 10 to the power 5 copies per ml. You know, so those are the patients with active replication. So those are the patients we need to treat. Or if you have a patient aged between 35 to 40 years and the liver biopsy result shows fibrosis stage 2 and above, even in the absence of positive E antigen or in the low viral load, you know, we still need to treat them with the biopsy result from stage 2. We also treat patients with inactive hepatitis B, those who are healthy carrier prior to the initiation of immune suppressive therapy. Let's say that this patient, you want to put him on steroid or any suppressive treatment. Although he is a healthy carrier, you know, it might induce, because of his immune status, if you put him on a steroid, he might develop an active replication. And we also treat patients with superimposed chronic hepatitis D infection. So those are the indications when we can treat. Now, what are the options? The current option we have, we can use nucleoside analogs like a 3TC that we call lamivudine, you know, because this suppresses the virus, the hepatitis D DNA in the serum, and it improves the liver histology in 60% of the patients. It will normalize the ALT in more than 40% of the patient. So it's actually a good one to prevent even relapse. You can also use entecavir. Entecavir is a preferred first-line oral agent, and it's rarely associated with resistance, you know, because patients who have been exposed to 3TC for other reasons, they might develop resistance. So entecavir is a good option, and it also improves liver cells histologic improvement in 70% of the cases. So the only problem is that it might lead to lactic acidosis when used in a patient with decompensated cirrhosis. We can also use nucleotide analogs like tenofovir. Tenofovir is the preferred first-line oral agent with substantial activities against hepatitis B and a low rate of resistance. We also have long-term use of tenofovir might lead to increased serum creatinine levels and the decrease of serum phosphate levels. So that's what we call Fanconi-like syndrome. But this is reversible once you stop the use of tenofovir. We also have pegylated interferon alpha that can be used. This is alternative to oral agent in selected cases. You know, we can use that in patients with low baseline viral load, but with a high ALT levels. In patients who are infected with genotype A, you need to give them pegylated interferon alpha, and also to avoid long-term oral treatment in young women who want to become pregnant. So we use these antiviral treatments. Now, the pegylated interferon beta can also be used in patients, especially patients who are superimposed with a chronic hepatitis D infection, you know, so you can use this one. In conclusion, hepatitis B is a viral infection that attacks the liver and can cause both acute and chronic disease. And the virus is most commonly transmitted, we say, from mother to child during birth and delivery, as well as through contact with blood and other body fluid, including sex with an infected partner, injection drug use that involves sharing of needles, syringes, or drug preparation equipment and needle stick, or exposure to sharp instruments. So hepatitis B can be prevented by vaccines that are safe, available, and effective. So thank you very much for following this presentation on hepatitis B infection. Don't forget to follow us, the part 4 of this lecture, where we will discuss hepatitis C infection. Thank you and goodbye.